the coronary high-risk indicated patients.
Assalamu alaikum wa rahmatullahi wa barakatuh. Thanks for the organizer of the GIS to let me be here for the 5th or 6th year consecutively. It's excellent meeting. I'm proud to be here. Actually, talking after Dr. Shazia is difficult because it will be very practical, and I'm sorry, I'd like to be interactive most of the cases, okay?
Okay.
So let it be interactive. This case, before knowing his age and the data, they sent me the CD. He was in another hospital, and when I saw the CD, actually it was on the mobile. In a busy day, I told the doctor that was in between, no way this is a surgical case. And actually, after 1 or 2 days, he told me, okay, I'll send you the patient. He preferred to do the surgery in your hospital. And when the patient arrived, I've also talked to the surgeon, and he saw the angio, and then he came down to me and told me, wait a little bit, the patient is 90 years old. He's 89 plus 11 months. This was the case. Actually, he's a professor in the University of Alexandria. He's active. He's still going to 2 days per week giving lectures, and he's very active. He has walking exercise in our club in Alexandria, and he presented with acute coronary syndrome, acute heart failure 20 days before he arrived to us, with pulmonary congestion and severe mitral regurgitation. The lab test showed CKD with low GFR. ECG shows sinus rhythm and T-wave in the inferior as well as the lateral leads, anterolateral leads. His echo showed an ejection fraction of 38 with severe infralateral hypokinesis and moderate to severe aortic regurgitation. And this is angio, which has been done in another hospital, and I've shown it on the mobile, and I spoke with the surgeon, and the surgeon accepted the case, but with his age, you can appreciate the calcium, you can appreciate the CTO or occlusion of the circumflex, occlusion of the RCA. I think one of them is fresh. Here is the angio once again. Severe calcification. The left main is short and good target vessels. The ramus is graftable, the OM is graftable, the LAD is graftable also. The surgeon didn't deny. And this is the right. So let's have the questions.
Let's stop. Yes. Yeah. This is an elderly, 90 years, acute coronary syndrome, CKD 34, ejection fraction 38, viable, and they have a high syntax score. What are you going to do in Tunis?
In Tunisia, I would be surprised to find a surgeon who would accept this kind of patient.
Okay.
But if I find a surgeon who accepts the patient, definitely this is a surgical case. It's not a matter of age, actually. It's a matter of risk score. So if the risk score in general is acceptable, then surgery would be the best.
The patient is 89 or 90, but he looks he's 76. He's very active and he's in a good shape.
So surgery would be the best option. But now, if there's any problems with surgery, something needs to be done. But it's going to be high risk anyway, if it is percutaneous.
Okay. Hazim, surgery or not, and which artery to start if you go to PCI?
I will do for this patient staged PCI, but we must prepare our team, our cath lab, with the intravascular image, with assistant device, all the modules for calcified coronary vessels. I think this is the
and mechanical
way.
Support on?
Of course. I told this.
Yeah.
We need assistant device.
In the United States.
I would definitely get a surgical consult, but I would say that I understand the cardiac mortality, the surgical mortality is quite high. So, but you need to have the patient understand what the options are, because none of the options are great, honestly. Right? Even PCI is high risk, but I would want the patient to completely understand how high risk this is. And then I would approach the PCI if that's what the patient wanted. Definitely put in an Impella before I would approach
Which art are you going to start?
LED.
LED.
Yeah.
Yeah.
So let's be honest, let's not forget about the biological age. But I think key in this case is actually to talk to the patient and give the option. The surgeon would be consulted as well, but no surgeon would take him, and it would be a high risk. I would go definitely for the LED, the left system.
The LED. Okay.
England.
I'd be very controversial and be 100% sure that medical therapy is not an option for this patient, in which case I would.
So
Well,
now,
prognostically, we're not going to make a difference. It's
no
all about
surgery?
treatment of pain.
Okay, Amr. And then no surgery. Our team is okay, but comfortable with which starter to start.
Okay.
Can I ask the audience?
Yes.
Who is going to start with the LED? Raise your hands. Who is going to start with the OM? Who is going to start with the right coronary? Right coronary.
Yeah.
Yes.
Okay. Okay. So we don't have the correct answer till
Okay.
now.
Let me tell you what we did. Actually, we did a very fruitful heart team. I sit down with the surgeon first, with the anesthetist, both of the three. We took our time for 20 minutes. Then we brought the daughter, which is very well educated, and his grandson. He came from UK, and another half an hour explaining everything, because the surgeon accepted, and it's mortality. So there is a mortality, and only for his age. And then the family told us he will take the decision. Then we came up to the patient himself. He's on intermittent CPAP, and we took up the CPAP, and we were talking to him. We explained everything, and the patient had chosen after half an hour. He brought my hand and told me one single thing: if I'm going to die, I'd like to die with you. And this was very.
Amr, can you show us again the film again, please? Yeah. LED is heavily calcified lung. There is no target for the vessel for the surgery again. Then look for the obtuse marginal. Look for the circumflex and obtuse margin. The right coronary has a received collaterals, retrograde.
And the
collaterals.
OM also is receiving collateral.
And the OM is.
Yeah.
So the culprit is difficult for.
Yeah.
Okay. Show us how do you choose the
Yeah,
culprit.
Dr. Adel, yeah. What do you think?
What's culprit?
If there is culprit, yeah, because if you're going to do it staged,
It's non-ST.
Can I just make a comment? Did
Yes.
you discuss with the patient a hybrid procedure?
Yes. Good
yes,
option.
yes, all of the options.
Lima and then
All of the
start
options.
working on the other vessels. This was an option to minimize the duration of anesthesia and the risk of anesthesia.
Yeah, we spoke with all the options, but actually the LED looks easier for us. So if hybrid, the RCA, maybe one of them is CTO, definitely. The RCA or the CX. Also the ramus or the diagonal is very, very big and calcific also. So let's...
Amr, was the off-pump option discussed?
off-
Was it
Yeah.
off-pump?
Off pump?
Yeah.
Okay, let me tell you what's my strategy when we decided to take the case. Actually, we decided to go femoral, 7 French, bilateral femoral access, because we don't have Impella, but there is intra-aortic balloon pump. It was standby. And then I sit down in the cath lab with my colleagues, the manipulator and the infirmier. They are well aware, and most of them told me to go for the right. Why? Just to secure the patient. Actually, going to the LAD is very, very risky. And I ordered an ultrasound kidney. The ultrasound kidney, the kidney was normal. So the CKD, there is something going on. And the severe mitral regurgitation is responsible for the severe pulmonary congestion. So I thought about the OM. And that's what I did. I decided the OM will be the culprit first, and then I'll go staged after 4 or 6 weeks, if everything is going okay, and I'll do the rest. So this was my plan. And actually, it was right. This is pilot 150. After some negotiation, it crossed, and this is a balloon with no or very little amount of contrast. We did this circumflex, okay? Stenting, pot or post-dilatation, and then excellent result. This was only about 40 milliliter contrast, and this was the final. So my question here, because most of the cath lab, when I took only half an hour and the low contrast, they told me proceed. We have the intra-aortic balloon. But I said no. I'll give the patient the test. If the mitral regurgitation will be better, if he is going to be better, we'll go for the LAD because there might be complication. And this, yes, we know that the trials...
Before you go to this, Yani, this is the culprit, and you succeeded to make the culprit.
Yes.
Now these patients acute coronary syndromes,
Yes, here is the...
and the heavily calcified LAD. If you're going to treat the LAD, are you doing ROTA in acute coronary syndrome? This is the question number one. ROTA, one of the contraindication is acute coronary syndrome. The high troponin, it's Sonori flow. So is advisable to Amr, when you see this patient, to continue or to postpone, and when?
Well, his renal function is not very good. So even if you only use 40 cc's of contrast, I would stop here and wait.
Yeah.
Give the time to see how he does.
Yeah.
And, you know, and again, obviously you're medically therapizing this patient also. You want to see, you said he's very functional. So I don't think, Nick, your idea of even trying initially the medical therapy, but I mean, I think the anatomy was such that, you know, so it precludes it, but I would stop.
Okay.
Okay, go ahead.
Okay, that's what, because most of the trials have shown that complete revascularization in the acute coronary syndrome is better. This is the BioVasc and the multi-star, but despite of all of this, there is still here the non-ST acute coronary syndrome complete revascularization is 2A. That's why we stopped and we evaluated the patient. The patient, after 1 week in the hospital, he improved a lot. We get the heart failure improved, ejection fraction started to improve, and astonishingly enough, after 2 days, the renal function improved. So we discharged the patient home, we closed follow-up, and then we did serial blood urea and creatinine, and then the patient improved. The family told me he improved completely.
طب أنا
Yeah.
in STEMI, we know that this is a complete revasc, it's okay, either in the hospital or index hospitalization or
Yeah.
up to according to the complete trial.
Yes.
In non-STEMI,
Yeah.
we have the multi-stars, we have SMILE, we have BioVasc,
Yeah.
and there is,
I've mentioned them
yes.
here. Yeah.
There is no definite answer when to
Yes.
do complete revasc in non-STEMI. Do you have an answer in the United States?
No, but I mean, I think the data is compelling to do complete revascularization, and STEMI is the presentation, not necessarily a non-STEMI. So again, this is not a STEMI, so
Yes.
I don't think that this is the issue of doing complete revascularization at the same
yeah,
time.
in the same hospital. So, well, that's what we did, and after 6 weeks,
Yes.
Well, okay.
Dr. Amr, it's an amazing case and the decision is amazing. But why would you discharge the patient with subtotal LAD? You can do him after 1 week and
yes,
so when-
it's a very good question. But I'll tell you what I was thinking about. This patient was giving his lecture. He's going to the sporting club. He was walking and giving his lecture with this LAD, without dual antiplatelet. Okay? The responsible was the circumflex that brought him down. And now he improved a little bit. I won't rush and do it after 1 week because the kidney function is improving and the ejection fraction is improving also. So going to the LAD and RCA, both are complex. Within 1 week, I prefer to stay with close monitoring the patient. I told them if anything happened, go to the hospital, we'll do it anyway. And I think I was right because let me tell you this. We completed with the LAD because there is other option to open the RCA first, but I think no, complete the left system. The left system is very important. And the LAD, sure, we're going with ROTA. And now it's not necessary to have, but I have the intra-aortic balloon pump, but it's not necessary. The ejection fraction now was 50. Okay, the mitral regurgitation was mild to nearly absent. So we are working in better situation. And what has happened, this is after ROTA, this is 1.5 ROTA, we have a stack bar. Up. This was expected. I was expecting difficulty. Okay, in 89. So fortunately, we didn't do it in the same session because the patient can compensate a little bit, or 3 to 4 minutes with the stack bar. What to do? Here is my colleague, Dr. Ahmed, has sent me this. This is the scenario, how to deal with the stack bar. Second guiding, ping pong, and then cut it and just snare or go with the balloon, dilate, and all of this. It has not been written, but this is for the third time. I'm telling you what to do first. When you have a stack bar, just put the rota device off power, and then open it for repower and recharge it. And then I started rota once again, but not taking it out. I just, and then retire. It worked.
Like the car.
Yeah.
You close the car, open the car.
It's not been written. This is the third. Yeah, this is the third time I did it, but it has been not
okay.
mentioned
I know,
anyway.
I know.
Just put the power on for this patient twice. On, it didn't work. Off again, and then on. Just charge it, and then go.
Forward.
Yeah, and rotate.
Okay.
And then retire it. It worked.
Go ahead.
Then it worked. Did it once again, but at 200,000 RPM.
Also, this is today.
Yeah,
we heard about 200.
and picking with a very high speed, even 220 to cross. Yes, this is to cross. We crossed the
1.5?
first. Still, there is a.
This 1.5 or?
This is 1.5 and then 1.75. I took
Okay.
1.75 without imaging, of course. I know it's we are doing the practical daily work. So I took this balloon, and then the balloon is okay. Bigger balloon. We had the test, and it's 1.35. What's next? It's easy. Just go to the distal lad first, stand the distal lad. It's after rotational. This is a long stand. And don't forget about the ramus. The ramus is heavily calcific. We were ready with the rota, but we took a balloon, and finally, because I didn't want to get the wire of the LED, and it worked, then stenting the ramus. The ostium is free, so you shouldn't go to the ostia. The ostia is free. Don't complicate it. And then this is the LED. And don't, despite it's a heavy procedure, don't fatigue and end with kissing. And this is what the final result. Actually, this has been 6 months ago or 5. Yeah, the second one, 5 months ago. The patient is wonderful shape now because I told him to come back after 3 months for the right coronary.
Okay,
He told me, no,
I'm coming to these questions. Are you satisfied with a good collateral to the right in a man 90 years and to have complete revast for the inferior and the anterior wall, and part of the inferior is already collateralized by natural bypass to the right coronary, and you leave this? Is it routine to make it in your practice in a difficult case, or you have to continue to do the CTO? Hazem.
I will try to have evidence that I need to do the C2RC, huge ischemia to do it. This is my.
Can you ask for nuclear if more than 10 to do it, or
yeah,
just
yes.
if asymptomatic, leave it?
No. Non-invasive test.
Ahmed,
Objective test.
Yeah. Sorry.
Yes, Ali.
It looks like the circumflex is the dominant vessel, and the right coronary artery most likely is a small one. I don't know if you have seen it differently.
Yeah.
But after having seen the circumflex, which is a huge vessel, I imagine the right is not really dominant, and maybe it's not worthwhile to.
Are you going
time.
to reschedule the syntax? I mean, residual syntax score, this is less than 8, for example, you leave it?
I mean, I think your question initially was, should you do the right? And I
Yeah.
think in a 90-year-old with this result, less is more. So I think leave them alone.
Okay. And you?
Yeah,
You doing it in Saudi Arabia, or all the CTOs you have to do it, or depending on evidence?
It would depend on the evidence easily, but I would make sure, because if I take the decision to treat the left system, that I would completely optimize it.
Okay.
So it
England.
would be definitely a measure.
Leave it?
I would leave it. The circumflex is improved the heart. The proof is in the pudding already. The inferior wall is improved. The LV function is improved. And prognostically, you're going to have no impact here at a 91-year-old.
I think your answer is here in the last slide.
Yeah,
Yeah.
we left the patient. My key home message is here. is the elderly as very delicate. You should take him patiently and cautiously, and not every elderly like each other. He's very active man. And my second take-home message, steps taken step-wise and step by step is much more important to achieve success than heroic action from the start. Thank you.
You have a